Dr. Jay Sridhar from the Bascom Palmer Eye Institute in Miami, Florida, and I have the pleasure of bringing you this new Retina Radio Journal Club with Vitbuccal Society VBS. I'm joined by three of my friends and colleagues from around the country. First, in alphabetical order, Dr. Sabin Dang from the Retina Institute in St. Louis. Welcome, Sabin.
Thanks, Jay.
Next, in alphabetical order, Dr. Brian Doe from the Retina Group of Washington and also an assistant professor of ophthalmology at Georgetown University in Washington, D.C. Brian, welcome.
Thanks for having me.
Last but not least, Dr. Avni Finn, who is in the Bay Area as part of Northern California Retina Vitreous Associates. Avni, welcome.
Thank you, Jay.
So the first paper we're going to talk about, the title is Primary Retinal Detachment Outcome Study Report Number 2. This is the PRO study group, and this was the phakic retinal detachment outcomes. Avni, you want to tell us a little bit about this paper?
Sure. This paper, the main objective of this paper was to compare methods of repairing phakic primary retinal detachments with three different methods. And we know that, depending on the surgeon, you might get three different approaches or opinions for how to repair a retinal detachment. And we don't have many great studies really helping us compare these surgical treatments and the outcomes. So this was a really data-rich study looking at three methods of repair: primary scleral buccal, primary vitrectomy, and then combined buccal vitrectomy, and looking at the outcomes of these three methods in repairing phakic detachments. This was a multi-center retrospective study, and their primary outcome measure was a single surgery anatomic success, which they defined as retinal reattachment at 90 days without a return to the OR. And then secondary outcomes they looked at was final visual acuity. And although this was a retrospective study, they did a really good job at controlling for a lot of confounding factors and those that might influence a surgeon's decision to choose one procedure over another. So for example, they excluded patients with any sort of trauma, any sort of like proliferative neovascular disease or uveitis. They excluded characteristics that strongly weighted patients towards a primary surgeons towards a primary vitrectomy, like the presence of vitreous hemorrhage, the presence of any PVR, having a significant cataract or a GRT. And then also kind of excluded factors that influence surgeons towards doing a primary buccal, like a young patient aged less than 40. And then those that we might choose, more often to do a buccal vit, like a really extensive detachment more than 9 clock hours. And so out of a total of over 1,000 phakic RDs, they included 715 surgeries in this study. And in short, what the results showed was that the single surgery anatomic success rate was the highest with scleral buccal at 92%, followed thereafter by scleral buccal vitrectomy combined at 91%, and vitrectomy alone was at 83%. And they found that doing either buccal or combined buccal vitrectomy was significantly superior in terms of single surgery anatomic success to PPV alone. And what was also interesting was that these anatomic outcomes were superior even when you accounted for the status of the macula. And then their secondary outcome, which was looking at visual outcomes, scleral buccaling also had significantly better visual outcomes than the PPV or combined PPV buccal group, even when they looked at the formation of cataract and macula status.
Fantastic summary. And before we dive into discussion, always important with these papers to discuss limitations. So any big limitations our listeners should be aware of?
Yeah, I think some of the limitations that, first of all, it was a retrospective study. So you can't control and there were multiple surgeons involved. So you can't control for a lot of the surgeon factors, which is why I think a lot of these surgical studies are, oftentimes you have to kind of take the results with a grain of salt because everybody operates differently. You can't control for how much vitrectomy or shaving is done, those sorts of things. I think the surgeon factor is probably the most important thing to consider here.
Let's dive right in. Brian, I think Avni really hit the biggest point here, and the big takeaway everyone's discussed is this comparison of buccal alone versus buccal vit versus vitrectomy alone, single operation success. And we can debate later whether single operation success should be a metric that's used to judge the success of retinal detachment surgery. Other studies have looked at final visual acuity or at final anatomic success, regardless of the number of procedures. But we'd just talk about single anatomic surgery success. Does that surprise you? I mean, and how do we kind of balance this in our minds with the idea that scleral buckles are declining, actually, not increasing over time in their use amongst American surgeons and surgeons around the world?
So, having come from a training program where, the use of buckles, especially in phakic attachments, was emphasized, I'm not particularly surprised by these data. Avni touched upon, the fact that, these data are retrospective and, the study's not perfect, but, given the circumstances, I think, the folks who put these studies together really did as good of a job as they possibly could have, accounting for things that would have potentially skewed surgeons and practitioners in one direction over the other. What they wanted to do was present cases where, again, there weren't factors that were going to skew strongly in one particular direction. Clearly the use of scleral buckles, at least, primary buckle for the repair of retinal detachment has declined over time. But I'd like to think that, at some point we'll hit sort of a steady state. As somebody who trains fellows like most of us on this call here, I always tell my fellows that I've never regretted putting a buckle on, but certainly have encountered situations where I wish I'd put one on in hindsight. So I personally don't think that my practice is going to change much. I'm going to continue to push forward with buckles and encouraging my fellows to do them.
There's a couple other interesting points to break down. And it's a retrospective study. Avni brought that up. So it's interesting to kind of think, well, the surgeons made their independent decisions. What kind of influenced those decisions? They may have their own practice preferences, but maybe there are some RD characteristics that differ. And if you look at for example, the quadrant that was involved, depending on the surgery, inferior detachments primarily make up or infratemporal and supratemporal kind of even in the scleral buckle group, versus in the vitrectomy alone group, it's more than half of them are supratemporal, fewer inferior detachments. And that's kind of interesting because inferior detachments typically are a risk factor for PVR or redetachment, but we still had a higher success rate in the buckle group. It's also interesting to look at the MAC on and MAC off kind of split in terms of what the characteristics were going into surgery. The buckle group, the majority of the patients were MAC on, 57% almost. The vitrectomy group, they were leaning more towards off, and same with the buccal vitrectomy group. And it's interesting, Sabin, I don't know what your thoughts on that. It's not really a teaching point, at least where I was taught, that MAC off versus MAC on should influence your decision about which surgery to use. Maybe there's other factors that were confounding that we aren't seeing here that were measured. But what do you make of that? Do you think that the macula status should influence the choice of surgery? And why do you think it did? And when you look at this retrospective data?
Yeah, so my practice pattern matches yours, Jay. I do not use macula status to determine what my surgery is going to be. I'm going to look at where the breaks are, what the degree of peripheral pathology is, and make whatever is the right assessment for that eye. But I do wonder if surgeons have their quote unquote A game, that this is their go-to surgery. If the stakes are high, this is what they're going to do. And I do wonder if they feel like the pressure is more on these macula on 20/20 eyes, and do they feel the need to preserve that 20/20 vision by doing something differently than they would for a macula off detachment that they feel like, well, they've got some wiggle room. The macula's already off, the vision's already down. So I think that does end up playing into our psychology. I mean, at the end of the day, we can see a lot of these patients as add-ons to the OR, and that can also kind of impact your decision making as to OR availability, how much time you get. And that's one of the things I really liked about the PRO study is I thought this got to as real world as you could possibly get. There are so many factors when it comes to reattaching the retina that we don't consider. I don't know about your guys' environment, but sometimes hospitals are not available to us to operate on, and we have an ASC time, and we have 60 minutes to get in and fix this eye for a macular detachment, and that dictates what I'm able to do sometimes. And so that's the real world. And I think the PRO study is really getting at that by looking at the real world at large centers who are repairing a lot of detachments.
Great points. And Avni, just kind of tie this with a bow, the other big outcome was this visual acuity difference where scleral buccal group had significantly better visual outcomes than vitrectomy. They referenced that this was seen in prior studies. You go back to the early 90s, SPR studies show this. And it's interesting that we've never been able to fully answer why that is. There's been some theories about retinal reattachment, how you reattach the retina. Is there some sort of displacement? Thoughts on the differences in visual acuity outcomes independent of surgical success?
Yeah, I mean, I think it's really interesting because they also make the point that even though the buccal group had more MAC-on detachments, it was the visual outcomes were regardless of that MAC-on MAC, status. So, I think it's really interesting. We've seen similar results in like the pivot study where they looked at, pneumatics having better visual outcomes, and I wonder if some of it is we in this study we don't really look at ERM formation or metamorphopsia, but that can of course affect visual outcome. Other people have sort of hypothesized that the RP pump working naturally maybe in those primary buccal groups is what really kind of helps them reattach in a more physiologic way and leads to better visual acuity. But I think the short answer is we don't really know, but we do see this effect that is important to know.
And if you're right, there may be ripple effects in terms of if we do a vitrectomy, how should we drain? And people have debated the best way to drain to get the best visual outcome. So let's shift gears, but not completely, because it's been said the PRO study is fantastic for many reasons. We've got a second paper from the PRO study. This is primary retinal detachment outcome study, pseudophakic retinal detachment outcome. So this is PRO study report number 3. There's a whole bunch of these. And this one is looking at the pseudophakic patients. So Brian, tell us a little bit about this study and the results.
So Jay, similarly to the study that Avni just finished up summarizing, in the study 3, the folks who put the paper together, instead of comparing scleral buccal vitrectomy and combined buccal vitrectomy, they looked only at vitrectomy and combined buccal vitrectomy, just because the number of cases in which pseudophakic detachments were repaired with scleral buccal alone was really small. And so again, this was a multi-center retrospective study. Drawing from 6 centers and, their surgeons' experience. They also looked at, single surgery, anatomic success, as well as final visual acuity. When looking at these patients and their retinal detachments, they quantified the detachment based on clock hours per quadrant. They also sort of specified whether, these were majority superior or predominantly superior, and same for the inferior hemisphere of the retina, where, majority superior retinal detachment could be, 6 clock hours of detachment superiorly and 5 clock hours inferiorly, whereas a predominantly superior or inferior detachment could only have a maximum of 1 clock hour on the opposite side of the horizontal meridian. They looked at macular status, where they classified retinal detachments as MAC off, MAC on, or fovea splitting or threatening. And ultimately, they had 893 eyes to look at. 684 of them underwent vitrectomy alone, 209 combined buccal vitrectomy, 36% were MAC on, 53% MAC off, and 11% MAC splitting. When they looked at the single surgery anatomic success rate, it was about 84% for those who underwent primary vitrectomy, and 92% who had combined buccal vitrectomy. And there was a significant difference there from a statistical standpoint. And when they looked at, macular status and sort of anatomic location of the detachment, the single surgery anatomic success rate was higher in the combined buccal vitrectomy group for all subgroups. Looking at the few late redetachments that they had, so 25 out of the 893 patients, they did well at 3 months and then detached later on down the road. 20 of those 25 were from the primary vitrectomy group. Looking at the demographics of the patients, the folks who underwent combined buccal vitrectomy, they skewed younger. They were more likely to be MAC off. They had worse preoperative visual acuity and more involvement of the inferior quadrant. So again, it's impossible to eliminate selection bias completely, especially in a study like this one, but I think they did as good of a job as possible. Interestingly, preoperative visual acuity was better in the primary vitrectomy group, although postoperative visual acuity was not significantly different when you compared primary vitrectomy to combined buccal vitrectomy. And that may have been because the folks who did poorly after primary vitrectomy sort of, brought the average visual acuity down. As far as predominantly superior versus inferior detachments, a higher percentage received a primary vitrectomy if they were predominantly superior, and vice versa. for combined buccal vitrectomy. And when they looked at majority inferior and majority superior retinal detachments, there really weren't any differences. They also looked at differences in single surgery anatomic success from gauge of vitrectomy used. So I was surprised with how many of these cases were done with 20 gauge vitrectomy. I've never seen 20 gauge done myself. So between 20 gauge, 23, 25, there really wasn't any difference. They also looked at differences between tamponades used. Between SF6 and C3F8, there didn't seem to be much of a difference, but with air or silicone oil, the single surgery anatomic success rate was a little bit lower. Interestingly, the SSAS or single surgery anatomic success rate in predominantly superior retinal detachments in the primary vitrectomy group was higher with C3F8 than with SF6. And I don't think they had a good explanation for that. As far as, macular status, MAC-off detachments, single surgery anatomic success rate was about 83%, MAC-on slightly better at 90%. But again, when they looked at, vitrectomy versus combined buccal vitrectomy, SSAS was significantly higher regardless of macular status. So, I would say that, these results were consistent with what we read and heard about from Pro Study 2 in the phakic subset.
Fantastic summary. And there's so many tasty morsels to kind of break down. You did a great job of summarizing all of them. Sabin, let's talk about the first one I want to reference, which is, again, sort of that skew we talked about. Macular status, does it influence people's decision here? Very slight, but if you look at the breakdown MAC off versus MAC on versus split, 75% of the buccal vit group was MAC off or split versus 60%, and 15% doesn't seem like a big difference. We have big numbers like this. So again, there does seem to be a tendency, maybe it's just unconscious with the surgeon. Maybe there's other factors, again, we're not seeing, but maybe we just see things that look worse and we're just like, this needs a buccal. And maybe it's more appropriate. Maybe the MAC off detachment's more chronic. I think there's a higher risk of redetachment. That's one thing to comment on. And the other thing is the extent of the detachment, tends to involve more of the inferior quadrants when you're talking about preoperative characteristics. Again, do any of these kind of influence your decision whether or not to put a buccal on? And what sort of things do make you inclined to place a buccal when you are doing a vitrectomy?
So it's such again, going back to the original discussion, it's really about the peripheral exam. And I think what you're kind of alluding to is that when you have somebody with a macula-off detachment, the probability of there being more peripheral pathology, or perhaps even just a inability to fully assess the periphery and fully gauge how much we are talking about stiff retina, or are we getting early PVR? I think those are all factors that play in the decision making, but may not always make it into the documentation. So again, one of the limitations here is that this is a retrospective study, and I feel like there's a lot of that decision making that goes in internally, but may not actually make it to the chart when you're looking at the stuff retrospectively. So I feel like that is a part of it. And going back to my earlier point, I do think the timeline to repair, having the urgency of a macula-on retinal detachment does place some constraints on what procedure you are able to do in a timely fashion. And sometimes that may skew some surgeons more towards vitrectomy and others not. And I think there's the psychology aspect. You want to do your A game, or you want to be as minimally invasive as possible by, I don't want to put a buckle on this because they're already 20/20. I think all those play a factor.
Great point, Sabin. And to your last point about, the question of refractive status, vision, we sometimes have that decision. If someone's been MAC off for a while, maybe it's less important to us what the refractive status is. We're just trying to get the retina attached. Maybe we add a buccal. Maybe that's skewing kind of the surgeon's decision making. Avni, any additional points about that idea about adding a buccal when you add it in a vitrectomy? And also, kind of moving on to the next question, if you look at the location of the detachments, you would expect, or at least based on things that are passed down sometimes, maybe inferior detachments would benefit more from adding a buccal in the setting of vitrectomy. Well, if you look at the single surgery success rate, it's kind of always better in the buccal vit group, regardless of quadrant. So how do you kind of resolve that? And does the location of the detachment then, did it influence your decision-making? And has that changed based on this paper?
Yeah, I think the first question, I think about adding a buccal sometimes when I'm not really sure where the break exists, and sometimes when a detachment is more extensive, that's when I'm a little bit more inclined to add a buccal to a vit. Especially in these pseudophakic patients, you can oftentimes have these tiny little breaks that are even hard to find when you're in there doing vitrectomy. And then, yeah, I'm really surprised actually about the quadrants of the detachments not really playing a role in the anatomic success rate, because I think about adding a buckle really most often in inferior quadrantic involving detachments. But it does make sense to me that, in these pseudophakic patients where you might have really tiny little breaks, you might miss breaks, and adding on that buckle really helps support those areas of potential missed breaks during surgery.
Great points. And let's get to like the $1 million question, Brian, which is some people are going to look at this data and said, okay, the buccal fit increases your data, but what's your number needed to treat, right? So you are increasing the success rate overall. If you just look at them head to head, right? You're going from a success rate in MAC off RDs 81% to 89%, and MAC on RDs 88% to 100%, which is great. Is that clinically significant? So some people would say, if they reattach, I can still get final anatomic success. And this goes back to this question of outcomes, right? So really, what's our big thing here? Are we saying, yes, we should add a buckle all the time, sometimes? Does this difference matter to you clinically? When do you add buckles for your vitrectomy patients?
So I will admit, maybe somewhat shamefully so, that when it comes to pseudophakic patients, Sabin touched on it to an extent. I try not to mess with the refraction, especially when folks have paid a good amount of money out of pocket for a multifocal lens or a toric lens, and that's something that I encounter somewhat frequently here. And they can always have keratofractive procedures done to sort of touch things up, but it's really difficult to say. I've anecdotally had good experience doing primary vitrectomy, even for predominantly inferior rhegmatogenous detachments in pseudophakic patients. Sort of sidestepping for a second, one of the things that they don't really talk about much here is positioning. And obviously that's difficult to standardize, and everybody has different principles and things that they like their patients to do. But I've personally had good experience with having patients side position for inferior detachments and inferior breaks, and whether or not this is something that a lot of these folks were doing, I don't know. But I guess even if they weren't, the results were pretty good. I rarely will add a buckle for first surgery in a pseudophakic patient, but have done so in cases where there are lots of visible breaks. Obviously any type of PVR will skew me towards doing a buckle at the same time as well. But for the majority of patients, I tend not to add one. The data that we saw here is similar to what we saw in the SPR study, where pseudophakic patients who had a buckle were less likely to redetach. And sort of did better overall. So, I feel like the folks who wrote the pro papers are trying to tell us something. And so, maybe I'll start, moving in the direction of doing more buckles in my pseudofakes.
Brian, you offered a very tasty preview of our next paper, but I'm not quite ready to move on to that subject. So we're going to come back to that thought about inferior RDs, but Sabin, I have two kind of thoughts I wanted to ask you about. He referenced multifocal lenses, pro con, right? Multifocal lenses, the patient prayed a lot for that. They can get multiple distance if they're happy with it. You don't want to mess with that. Con, sometimes in pseudophakics, it's hard to see the periphery. In multifocal lenses, sometimes we know intraoperatively it can be more difficult to see the periphery because of the different focuses, focal length through the lens. And I've actually noticed anecdotally, and we've kind of looked into this and we haven't finished looking into this, is sometimes those multifocal patients, you could put a buckle on them and it doesn't seem to change the refraction much. And I wonder if they're using like a different ring. I'm not a multifocal expert. I wonder if it's maybe allows them still to kind of see enough to maintain their intermediate as well as their distance. And my other question is, Brian brought up this idea of buckling. When do we buckle? And I've been asking all of you. Does age play a factor for you? We have pseudofakes who are younger and younger. We have young myopes now who are so eager to get out of glasses, they're going to go get early clear lens extraction. Does age or the degree of preoperative myopia prior to cataract surgery change anything for you besides your peripheral exam?
Those are great questions, Jay. I'm going to answer your last question first because for me, it makes a huge difference. I think the younger age patients, they have much more formed vitreous. And at the end of the day, I want to remove as much traction as possible. And I feel like my ability to do that in a younger patient may be hampered. And I'm so much more inclined to put a buckle on a younger patient. Regarding the multifocal IOLs, that is something that impacts my practice pretty significantly. I get calls from referring surgeons who say, "Hey, this is my post-op multifocal IOL. I did the premium everything on them. Don't put a buckle on them. I don't want the refraction to change." And my response is, at the end of the day, it's my job to fix that retina, and I'm going to fix it the best way I can because it doesn't help the patient if they stay chronically detached or they become count fingers or whatever. So it's a hard conversation to have with referring doctors, but I feel like it's an important point that yes, these patients paid for premium IOLs, but they did it because they value their vision, and we need to respect that and give them the vision, even if it ends up that they need contact lenses or refraction. The other thing that comes up in my practice, at least in the Midwest, is accommodative IOLs. And I don't know how many of you guys have had to work through repairing an RD with an accommodative IOL, but I have a flat out rule. I put a buckle on all those patients. I just cannot see through those plates, the plate haptics. I can depress, and there is so much pathology I might miss there. And for all of those patients, I just put on the buckle. So, no question, multifocal status does impact my decision on putting on a buckle.
And to that point, I'm going to reflect my age. Brian was like all these 20 gauge cases. Well, back in my day, young feller, we did see 20 gauge vitrectomies, and accommodative IOLs were all the rage at some point before multifocals. I remember as a medical student, all these accommodative IOLs going in. Thankfully, it seems like the incidence has gone down. Maybe regionally, Sabin, in your area, there's still are several patients with that. I actually agree. I actually buckle those patients pretty routinely as well. And we're just going to see more and more patients, though, as more multifocal options come out that are better and better. We're going to have to maybe try to work around that when we buckle patients. Well, thank you guys for contributing to this discussion. We're going to take a short break, and we'll be back with a couple more papers after the break. Let's move on to the next article, right? So the next article is our final kind of pro study report for now. This is retinal detachment with inferior retinal break. So Brian just touched on this subject. This is pro study report number 3, primary vitrectomy versus vitrectomy with scleral buckle. Sabin, take us through this. What were the designs of the study and what were the results?
Great. Well, Avni and Brian, you did a great job summarizing the pro study. So I'm just going to focus on the kind of specifics that this study was looking at. To kind of recap, why do we worry about inferior retinal detachments? And it's really we worry about them more because it's harder to tamponade inferior breaks. We talked about positioning. That is more challenging with this inferior pathology. And also we worry about PVR. Gravity is going to tend PVR to be inferior. And as that PVR develops, it's going to put traction on that inferior pathology. It may make new breaks. It may reopen breaks that we've treated with laser. And all of that can result in redetachment. So the question is, can we adequately address those risk factors with vitrectomy, or is scleral buccal vitrectomy superior in that? And so that's what this pro paper was evaluating. So it's important when we're looking at methods. We've already discussed its retrospective nature, and you guys are familiar with that now. But really, what was the inclusion criteria for this? So we can really map, our patients to this study. And it included patients who had breaks between 5 and 7, but it's important to note that it did not require those breaks to be the primary or even causative retinal break for the detachment. So these patients could have breaks elsewhere, and it could be a superior temporal break that is guttering down, and that's actually what's causing your detachment. But if you also noted an inferior break at 6 o'clock, then it would meet inclusion criteria. So it's not just inferior RDs we're talking about. We're really talking about, is there an inferior break, even if it's not the causative thing. So let's jump into the actual results. 238 eyes out of the entire sample met inclusion criteria. 40% of those eyes went through vitrectomy. 60% of those eyes went through buccal vitrectomy. Single surgery success rate was 77% in the vitrectomy group and 87% in the buccal vitrectomy group. This study performed a sub-analysis where we looked at just patients who were phakic, and the single surgery success rate for buccal vitrectomy was 85%, and the vitrectomy group alone dropped down to 69%. So there's a couple things that the authors point out in the discussion that I think are important. Number one is they flat out say, there's a lot of stuff out there in literature that says that people have achieved high success rate with vitrectomy only with inferior RDs. But again, one of the earlier points I made is I thought this was a great retrospective series because I feel like this is real world. This is actually what's happening in major centers. So even though there are case series there, I think that uh, this is probably mimics what we see in real life, at least in the United States. The other thing the authors are pointing out is scleral buckle is not a benign procedure. I mean, there is a lot of associated risk with performing scleral buckle. We are talking about extrusion. We've touched on refractive errors. There's diplopia. Um, and it's also a more uncomfortable procedure. At the end of the day, patients are going to feel that more. And so, we have to balance that in. And Jay, I think you brought up pretty good points about, what is the ultimate outcome? Is it single surgery success? Is it ultimate vision? And when we look at that, that's the final point that I'm going to make with this article is vision was not statistically different between the two groups. So we as physicians, when we're interpreting this data, we really have to figure out what is the most important thing to us. Is it one and done? The surgery is going to be, we're going to take care of it. I want to be, or you can say, I want to be as minimally invasive as possible. I'm going to do vitrectomy only, knowing that, hey, this study supports me in that if I do vitrectomy only and they fail, I can still get them to the same visual outcome. And you can argue both sides. I'd love to hear what you guys think.
Great summaries have been some really excellent points and really relevant to talk about risks of buckling, not just diplopia and extrusion, infection with drainage, suprachoroidal hemorrhage, incarceration if you're doing a straight buckle, and refractive shift we referenced earlier. Avni, we talk about buckling and the setting of vitrectomy. Does the phakic percentage surprise you? I mean, this is pretty low in terms of single surgery anatomic success. And again, to put this in context, Sabin did reference, there are studies that have shown a very high success rate for inferior phakic detachments with vitrectomy. That being said, this is a real world study, and the groups that are contributing to this study are prominent, respected groups. If you look at the groups that have contributed, the authors have contributed. So these are generally people you'd assume are doing best surgical practices. We all debate what those are, but this is a real world study, and it's telling you 2/3 of the time, yeah, you can get reattachment. A third of the time, you're going to have to go back. And so to me, that is the most stark example here of, is single surgery success? What's the number needed to treat? Well, to me, this is swinging the other way, where the number needed to treat here is, I mean, I need to save that 1 out of 3 patients from getting a reattachment. Now, 85% is not perfect either, but it's significantly better. Did that number surprise you? And then what is your general approach for phakic inferior RDs?
That number did actually surprise me, especially because we see a lot of case series that people report that they did vitrectomy alone on a bunch of inferior RDs, and most of those patients did quite well. And so it's hard to take those case series um, and extrapolate real world data from them, which is the closest this is giving us. And that did surprise me, but I think that there are reasons for that. It's harder to shave the vitreous completely in these phakic patients, right? So there's a surgeon factor there, and a visualization factor, and a reach factor of how much vitreous we can get out in these patients, and that can potentially lead to PVR and subsequent redetachment, right? So I think that that's a potential explanation for it, but the sheer number, I think, of non-successful surgeries with just PPV alone did surprise me. For me, inferior phakic detachments, there's almost no doubt that those patients are getting a buckle from me. I'm a big buckler, and if there's an inferior detachment, especially in a phakic patient, they're either getting a buckle or a buckle bit. So that's really kind of my decision tree on those patients, unless that it's really clear to me that that break is up top, somewhere superiorly, or even maybe like temporally or nasally, and that fluid is just kind of tracking down. Those are the cases where I might consider a primary vitrectomy alone.
Great points. And again, there's other factors, Sabin talked about this earlier, that are not captured necessarily, right? When we talk about pathology, we're not capturing the degree of myopia. We're not capturing the hyaloid status of these patients. Maybe inferior phakic detachments are more often to have the hyaloid down and have small breaks with a slow progressive detachment. I think most of us would argue, again, we're all biased, but we're retrained. We'd all argue that's probably a better candidate for a primary buckle or a buccal vitrectomy versus vitrectomy alone. And I'm biased like you. I mean, for me, phakic detachments, especially phakic inferior detachment, for me, it's buccal plus or minus a bit, not vit plus or minus a buccal. Brian, you talked about positioning earlier. And again, that's the other thing we're not capturing here is we don't know how these patients were advised to position. The classic teaching is face down in the old days, 7 to 14 days. Some people still do a week. I'm with you about side positioning for inferior detachments. Are there scenarios where you'll do an inferior phakic detachment as a vitrectomy alone? And let's take that one step further. Avni referenced a gutter detachment where the break is up top and there's guttered fluid. I'm saying if the break is below, like was described in this paper.
So the short answer is no. Like Avni, phakic inferior detachment with causative break or breaks inferiorly, pretty much 100% of the time, I'm going to be doing combined buccal vitrectomy, or like you said, primary buccal if the hyaloid is down. I suppose if I were to end up in a hypothetical situation where maybe a patient had a number of strabismus surgeries or something like that, and I weren't confident that I'd be able to get a buccal on safely and make sure it was well placed, I might consider doing a vitrectomy. But barring something like that or previous glaucoma surgery, which would also complicate the situation, I would probably plan to do at least a buccal and potentially do a vitrectomy. I just want to point out something else about these studies. We talked about them not indicating hyaloid status for these folks. I found it interesting that they just sort of used age as a sort of assumption or surrogate for whether or not the hyaloid may or may not be detached. But that for me is a big factor in my surgical decision making. I'm much more likely to go in to an eye if the hyaloid is up. And the converse is also true. If the hyaloid's down, I'm almost always going to try to take care of it with a primary buccal first.
A great point. And sometimes you also have that gut feeling that maybe the hyaloid looks up and your fellow says the hyaloid's definitely up, and you see this patient's a 24-year-old, and you're like, there's almost certainly vitreoschisis, and there's going to be another level, especially in the high myope. Avni, you had a point about tamponade regarding the study.
Yeah, I mean, so in inferior detachments, I think that tamponade choice is actually really important because those are the patients that I often think about putting in a longer acting tamponade because you want to support those inferior breaks potentially for a longer amount of time. So one of the things I thought was interesting was in some of the other pro studies, they did a lot of sub-analyses on the tamponade choice. And we didn't really see a lot of that here. So we didn't see, how many patients in the vitrectomy arm had C3F8 or even silicone oil that was removed later. Same with the buccal vitrectomy arm. So that would have been really interesting data, I think, to see and could have informed some of that anatomic success rate.
Or even temporary perfluoron, although Steve Charles, who's talked about that, was not a co-author or surgeon on this study. Sabin, on the topic of PFO, thoughts on PFO, silicone oil, tamponade choice?
You were reading my mind, Jay. As we were having this discussion, I was really thinking about PFO. So my take on this, just to clarify, is I love buckles for inferior RDs, but I am interested in alternatives. The ultimate reason we are worried that these are failing is, as I'd mentioned in the introduction, the inability to tamponade properly inferiorly. So if we were to do temporary PFO, can we be treating these patients more effectively? Is that all it needs, where they can do upright positioning, a little PFO bubble, bring them back a week or two later, take the PFO out, and they may be in great shape? And so I'm really looking forward to seeing that data come out as time comes on. And I do suspect that will actually improve primary vitrectomy rates, even in phakic patients with primary PPV. But at the moment, that's not something I'm willing to do with my patients, since I don't have the data to support it.
That's a great point. I'm gonna just comment. Avni may comment as well, because I know she trained at Duke, or Tamara Mood was initially doing a lot of these autologous transplants where you do stage with perfluoron in the eye. So I have done these macular holes autologous transplants, not to get off topic, where you put perfluoron on the eye and you leave it and you come back and take the perfluoron out in a different surgery. And the eye can tolerate it well, but there certainly is a point at which the eye develops inflammation, and PFO does tend to be inflammatory. And so my only worry, and I've heard of horror stories from doctors who have seen patients with PFO left in the eye, is do certain patients react poorly to that? Does it result in something different to highlight? I just don't have experience using it for detachments. And so the people who've spoken about it, like, Dr. Charles and others, are very, very prominent surgeons, and it's interesting to investigate, it'd be interesting to see the outcomes. But I think the other thing that you brought up that's interesting is, the idea of, has success actually improved over time? That's something that's not looked at with this study. This study is reporting from a single, year recently in the last 5 years. But have we actually gotten better at repairing retinal detachments in the last 10 or 15 or 20 years? And if you look at the single surgery success rate, pseudophakic, phakic, all these studies we've looked at, it's not significantly better than it was if you look at the studies from the 90s and 2000s. So you're right about pushing the envelope. Just because the single surgery success rate is not better doesn't mean we're not better with less invasive, less risky, better tolerated procedures. But are we actually moving the needle, or are we just changing kind of the different tools? They look cooler, they look fancier, they're fat, they're smart, they seem smarter, but we're kind of ending up with the same result. And that, you kind of started that point by saying you love buckles, and buckles have been done now for decades, well before vitrectomy was done. Avni, any thoughts on PFO left in the eye, since you've seen this in your experience?
Yeah, I haven't actually seen that many of these patients, but like you, some of these patients do develop really severe inflammation, and so that's something I'd be worried about. But a lot tolerate it pretty well. So I think it would be interesting to kind of see the data of people that are using it more widely and in more numerous cases.